So in chapter 26, we're going to talk about hypertension. Hypertension is often caused by sympathetic nervous system stimulation. It controls blood pressure. So in hypertension, there's increased sympathetic activation. So often how we block that is we will directly block that activation. The adrenergic neurotransmitters norepinephrine and epinephrine stimulate alpha-1 and beta-1 receptors to cause vasoconstriction and increased cardiac output. So we'll use alpha blockers, beta blockers, adrenergic neuronal blockers, and drugs that act on the vasomotor center in the brain to reduce sympathetic activity and lower blood pressure. And we are moving on to, try to keep up sometimes on this thing. We are moving on to slide 5. Blood pressure is determined by two factors, cardiac output and peripheral resistance. So how much the heart is putting out and how much the resistance the heart has to pump against. Other factors can influence blood pressure. So again, cardiac output is the amount of blood that is pumped out of the heart. Cardiac output is determined by the heart rate as well as how much volume is being pumped. Peripheral resistance we talked about was how much friction or how much pressure is against the heart that it has to pump against. So peripheral resistance is increased by vasoconstriction. A number of factors have been shown to affect BP. While these are not believed to be the cause of hypertension, they can cause it to increase. These factors include sodium restriction or overdose of sodium, weight loss or too much weight gain, smoking, exercise, and various relaxation techniques. Stress can increase blood pressure. So, diuretics we talked about in the last chapter will naturally decrease blood pressure because they're getting rid of some of that plasma volume, so they're decreasing cardiac output. They, again, cause excretion of sodium from the kidneys. Where sodium goes, water follows. And the hypotensive effect of these drugs is initially caused by excretion of sodium in water. However, over time, usually it takes several weeks of treatment to see a true effect, to have that vasodilating sort of effect. So right away we have decreased blood pressure due to plasma volume decreasing, and then over time, because they also have that vasodilating effect, we are causing less pressure, less resistance, so we're decreasing our blood pressure. We're going to talk a lot about sympathetic activity. We kind of already covered norepi and epi and the drugs that we can use to sort of block that. So centrally acting sympatholytic drugs, and what we mean by centrally acting is right on the brain, acts directly on the central nervous system to decrease blood pressure, and we're going to talk about clonidine here. Clonidine is a centrally acting drug used in the management of hypertension. The main action of clonidine is exerted on the vasomotor center located in the brain. These stimulate inhibitory alpha-2 receptors, so it reduces the activity of sympathetic nerves that travel from that area in the brain to the heart, so it'll decrease heart rate as well as cardiac output. It also affects the kidneys. It decreases the release of renin, which tells the body to increase the blood pressure. So if we decrease renin, we are decreasing blood pressure. It also acts from the brain, acts on the blood vessels, causing vasodilation, which results in reduced blood pressure. The adverse effects of clonidine include dry mouth, constipation, and drowsiness. We don't ever abruptly discontinue it because when we do, the opposite happens, hypertensive crisis. Doses are gradually tapered, kind of like prednisone that we talked about earlier in the module. Alpha, beta, and adrenergic blockers. These are not centrally acting. They're going to act directly on the blood vessels. The alpha-1 blockers are doxazosin, prazosin, and terazosin, and they selectively block alpha-1 receptors on vascular smooth muscle. This causes vasodilation and thus decreased resistance. It leads to lowered blood pressure. Beta blockers block receptors on the heart. They have two actions. They block beta-1 receptors on the heart, and they lower blood pressure by decreasing cardiac output, especially when there's increased sympathetic activity. Second, they also block the release of renin. So anytime we block the release of renin, we block the renin-angiotensin-aldosterone system, and thus we decrease blood pressure. Adrenergic neuronal blockers, guanethidine and guanidrone, not really used too often as much as alpha or beta blockers. These drugs prevent the release of norepinephrine and they deplete the amount of stored norepinephrine so that we can't have sympathetic stimulation. So slide 10 covers drugs that reduce sympathetic activity. Moving on to vasodilators, which we've also talked about in management of heart or chest pain. They act directly on vascular smooth muscles to cause relaxation, resulting in vasodilation and thus decreased peripheral resistance. They're often used in combination with diuretics and beta blockers. Calcium channel blockers also produce arteriolar vasodilation, so those will often be used too in hypertension. So our vasodilators that we talked about before, hydralazine was a common name. Main adverse effects: nauseousness, headache, hypotension, and reflex tachycardia. Minoxidil is a more potent vasodilator, but it's used for patients who have not responded to other drug therapy, usually triple combination. We'll move on to minoxidil. The reason we don't use it as much is because it has a number of serious adverse effects, including ischemia of the heart as well as pericardial effusion. So calcium channel blockers, again, we talked about their use in lowering peripheral resistance by vasodilation, and they are used in hypertension in patients with coronary artery disease, as well as, if we talked about Prinzmetal's, angina again. So they have a couple different uses as well. Slide 12 covers the different vasodilators that are out on the market. Slide 13 moves on to drugs that reduce angiotensin activity, or renin inhibitors, ACE inhibitors, and ARBs. And this is messing with that RAAS system, renin angiotensin activation system. And that, whenever we hear RAAS, or that long drawn out word, when we increase that system or we turn it on, we're increasing blood pressure. If we can inhibit it, we have decreased blood pressure. So renin inhibitors inhibit enzymatic activity of renin. And this is a newer class of drugs. Aliskerin was the first drug approved in this class. So it decreases the conversion of angiotensinogen to angiotensin 1 and reduces the formation of angiotensin 2. ACE inhibitors inhibit the formation of angiotensin 2 and decrease the release of aldosterone and antidiuretic hormone. This action lowers blood pressure by causing a balanced vasodilation in both the arteries and veins. Angiotensin receptor blockers act at a slightly different location, but sort of have the same exact effect. They're all messing with that renin angiotensin system. Slide 14 has a chart that talks about, maybe make it a little bigger, that talks about the mechanism of action as well as the therapeutic effects of these drugs. Hypertensive crisis treatment, and that's when somebody's blood pressure is ridiculously high and we need to bring it down quickly and safely. It can cause vascular inflammation as well as necrosis or death of blood vessels, so that's why we want to bring it down so quickly. Diazoxide and sodium nitroprusside are the drugs that we use here. Diazoxide is similar to thiazide diuretics, however, it's very potent. It's a very potent vasodilator without diuretic activity. Its effects usually last for 6 to 12 hours, and it can cause fluid retention, tachycardia, and hyperglycemia. Sodium nitroprusside is a potent vasodilating agent used in hypertensive emergencies, and it is sensitive to light, and this is one of those things that we talked about we don't let people handle because it can cause that severe hypotension. So it's sensitive to light, so we usually protect it with foil and baggies, and the duration of action is pretty short on this one, a lot shorter than the diazoxide. Patient education and monitoring. Some patients, half the patients who are walking around with hypertension don't even realize they have it. They're not diagnosed, they feel fine, and they just don't necessarily go see their doctor. Hypertension is a chronic disease requiring lifelong treatment and medical supervision. And patients should understand that if they have hypertension, they're putting themselves at risk for things such as congestive heart failure, heart attacks, and a lot of other problems down the road, which is why we encourage patients to get checked out. On our last slide, preferred therapy. It really depends on other existing conditions. For example, diuretics and beta blockers are effective in hypertension. ACE inhibitors and ARBs are the most frequently prescribed because they're also good for other diseases such as diabetes, heart failure, etc. And adrenergic blocking drugs would be for patients with excessive sympathetic activation. So that covers chapter 26. I'll be posting 25 and 26 tonight, and this is Monday, and recording 27 and 29 tomorrow night and posting those. Thank you.